Good evening and welcome to our second Global Surgery webinar for the year, done in collaboration between UCT Surgical Society and UCT Global Surgery. I'm Fumi and I head up the Global Surgery portfolio for UCT Surgical Society, and I'd like to thank you all for joining us tonight. We are appreciative of our local and international audience, as well as a wide array of audience both in profession and ranging from undergraduate level to senior academic staff. And this is all in keeping with the title of our panel discussion being The Future of Healthcare. And it's important to acknowledge that today we are joined by a highly esteemed panel, and we look forward to the insight that they'll be sharing with us today. So we will be discussing these topics today, and thank you all to those who've sent questions in already, and please do send through more questions throughout the discussion, which will be answered by our panel towards the end of our event. I now hand over to Prof Maswime, Head of Global Surgery, to introduce our incredible panelists and to start off the discussion.
Thank you so much for me. I always really enjoy these webinars that we have, and especially the partnership that we have with SurgSoc, which has really brought about this amazing program. This is the second webinar that we're having for the year, and if you recall, last time we also had an amazing panel, also spoke a bit about the future of healthcare, spoke about the sustainable development goals, the surgical ecosystem, infrastructure, and touched a bit on innovation. But today we'll really focus in on what innovation is, and we've got three amazing speakers who are going to talk about this. We've got Prof Justiaan Swanevelder, who's going to talk about innovation from a clinical perspective and talk about the advances in healthcare, but how the clinicians experience this and also the need for this. We've got Katusha de Villiers from the Graduate Business School, and she's going to talk about innovation and social change. We've got Prof Sudesh Sivarasu from the Biomedical Engineering Department, and he's going to talk about advances in technology and devices and what it is to be part of creating and designing new innovations. But the most important question is, what is global surgery? And I'll start there before we move into today's into the talks, and just reminding everyone and those who really haven't been part of these sessions that global surgery is about improving access to comprehensive, high-quality surgical care, particularly in underserved populations. And so all of this we want to relate back to innovation or finding solutions to improve access to surgical care. Innovation means a lot of things to different people, and that's what we're going to touch on today. And as we look at UCT, has got an amazing history of advances in healthcare, in surgical care, and innovative solutions. So on one hand, if you look at the one of the greatest memories that we have, or the greatest advances, was the first heart transplant. And so if I say innovation, some of you might think of innovation in theater from a surgical perspective, but it could also be a new device, it could be a new technology, or it could be a new way of thinking. I remember earlier this year, there was an article written about our division, and it was titled Global Surgery Fellowships, a first for UCT. That in itself was an innovation. And so we're going to look at innovation through different lenses. But without further ado, I'd like to invite the first speaker, Prof Justiaan Swanevelder. Prof Justiaan Swanevelder is the head of the Department of Anaesthesia and Perioperative Medicine at UCT, and he's also practices as a clinician at Grooteskier and at the Red Cross War Memorials Hospital. He was previously a consultant in anesthesia and critical care at Glenfield Hospital in the UK in mainly adult and pediatric cardiothoracic anesthesia and perioperative transesophageal echocardiography. He was previously a Royal College examiner, ACTA committee member, and member of the UK Joint TOE Accreditation Committee of the Association of Cardiothoracic Anaesthetists and British Society of Echocardiography. Welcome, Prof Swanevelder.
Thank you very much, Professor Salome and Dr. Funmi. It's a big privilege to be part of this esteemed faculty and to be involved in this webinar. I am, as Prof. Salome said, an anaesthetist and a clinician at heart. And I want to start by just saying it is all about people. Everything we're talking about and innovation is about people, and it's about socioeconomic innovation and disrupting our present status in a good way and turning it into a better functioning system. Yesterday I was in the operating theatre with a colleague from Cameroon and a colleague from Zambia and a colleague from Tygerberg, and for me it was a privilege how we could share and how we all come with some history and something in hand to share and to cross-fertilize each other. So we learn from each other. I am just going to briefly touch. 10 minutes is a very short period of time. So I'm going to rather put out a few provocative questions, and then we can maybe in the discussion time discuss that. But where do we start from? What do we know at the moment? What's the role of education? What should we really be doing? And can innovation improve how we do these things? We are part of a big continent, and we are actually, if you think of Pan-Africanism and how we are all from the same continent, then it is important that we realize that the xenophobia that we sometimes experience in our country should not happen. We should all look after each other, and it doesn't matter where you're coming from, we've got a common goal and a common vision, and we sit at the apex here in what I see as a privileged hospital. Now you can go 100 kilometers from here and people would not have the same access to medical and health care as you would have if you live in Cape Town. And that by itself is an inequality. So while we have rich and poor, the whole dream of global health care equality remains a dream until we can sort out the socioeconomic problems. And then we can talk. So if you are working today in a government hospital, in a public hospital, you are part of global surgery. You are part of changing, being a change agent. Remember that people from Harvard and Oxford and Cambridge, they all want to be part of this, but they sit there and they research what we are doing. We are actually on the clinical platform, and we are doing it wherever you work in this country. We must remember that we are dealing with different disease processes to what people really have in mind when they are in the developed world. Sometimes there are no answers and no treatments to some of these disease processes. Also, as an anaesthetist, we are working with different subspeciality of surgeons. We see it all. Whether it's ophthalmology, cardiac surgery, orthopedics, we work with all of those surgeons, and probably we've got the privilege of working with a broader spectrum of pathologies of all specialities. Also, because we work with different surgeons, that means that we observe their needs and their challenges. And often, as I may have the chance to show later on, innovation comes from standing outside, looking at people struggling on something specific, and then you may come up with an answer, which is not even in your own field. What are the factors contributing to poor outcome in low and middle income countries? It's no doubt it's access, patient demographics, the skills of the staff and the resources we have available. We can easily talk about ECMO and high care and critical care. However, in many other places, people are desperate to get their hands on a saturation monitor or a capnograph. So the infrastructure does matter. And then human resources. As I was preparing for this presentation, The WhatsApps just kept coming in on the shortage of ICU beds, high flow critical care beds, and beds for COVID patients. We are in desperate need in our privileged hospital of more beds. And we very seldom run out of machines or monitors. More often, we run out of people, healthcare workers, allied health, nurses. So there is no doubt that the investment must go into our human resources, developing them and educating them. Of course, we need to operate at a high standard. The governance is important, and then we have to measure it. So my question is, should we be focusing on global health, when at local level in our own backyard, health is not sorted out? Our own hospital has not got enough, let alone the rest. And you just need to have work to do a community service job somewhere in a rural area, and you would know the desperate need of people in other parts of our country. So global healthcare equality is still a dream we're aspiring to at the moment. People have researched very elegantly, and every department has done that. Every specialty has done that. I'm just showing our own department's very high-profile publications from led by Professor Bruce Bickard, and the ASOS trial. What does it show? There's not enough healthcare in Africa. The SAPSOS trial, there's not enough pediatric healthcare to provide good high-end surgery to children. The African ASOS2 trial, pilot trial, the ASOS2 is now at the Lancet for review at the moment. There's not enough, and not a high level. Patients die in the obstetric field because of mistakes and training and healthcare provision. We look at the recent, last month came out, the ACOS trial, again from our hospital, where it states critical care is not readily available to everyone on our continent. So really the whole point is there is not enough. So what should we be doing? I'm asking the question, when does the wealth of a nation really not make a difference to surgery? Of course, money matters. Of course, we need investments, but it also depends on that very important resource, which is you as a human resource. Every individual counts and everyone can make a difference. What kind of global health is the most useful and the least damaging to surgical units in developing countries, in our country? Definitely fly in and fly out, in-reach and outreach missions. It doesn't really work. I mean, you fly into a hospital somewhere in the middle of nowhere, do 10 operations and leave. No, we have to train people to provide their own service and to solve their own problem. And the same for us. We need to do that in our own backyard. Are we responsible for growing our own locally, provincially, nationally, and globally? Yes, of course. That is what matters. And we are privileged in our department and in and around us in the operating theatre to see people from everywhere on our continent coming here. And it's a privilege to work with these international colleagues because they bring information with them and you learn from them. So really, for me, it is always very exciting to hear where people come from and how they operate in their own setting. Professor Peter Ziller came with us, the Cape Town Declaration 2018, where he's just put big societies together. He's put big journals together and editors thereof. And the whole idea is that we solve our own problems, that people provide a way for the developing world to solve their own problems. And yes, we need money, but also we need expertise. Also, we need willingness and no obstruction. So the most important thing is that we are facilitated to help ourselves. Has democratization of knowledge led to any meaningful change at ground level? And if not, Why not? So nowadays you can get any theoretical information basically on the internet. Textbooks, virtual textbooks, and so on. It is readily available. The old days when the professor was the only one with all the theory in his head and the most clever one, and he tells you how it is, that's long gone. I'm learning from the young people every day in our operating theatre, from medical students, and it never ceases to amaze me how people come up. Suddenly things have multiplied, our information have multiplied, and it's that multiplication of information that is good for all of us, but also a challenge to keep up. I cannot keep up with everything people are telling me. The very important question is, can technical skills be transferred or shared virtually? Can you learn how to do an operation long distance? At this moment, yes, there are attempts. There are surgical departments who are doing things, innovative things to try and do that. But at this stage, our limitation is basically how much opportunity do we have for real live teaching. So if you're a surgeon, it's much more hands-on, and your manual dexterity is so important. You have to do the operation yourself to be able to do it. If you're an anaesthetist, it doesn't matter whether we are 5 people in an operating theatre. We can teach each other and learn from each other. It is not important to inject the drug yourself or to put in the neckline or arterial line yourself. This is all very specific to different disciplines. So Salome, I have spent my 10 minutes. I've got a lot more to say. The innovation part is in the latter part of my presentation. I'm not going to get to that. I'm going to stop here, and maybe during the discussion I'll have 5 minutes to just go through that. But thank you very much for this opportunity.
Thank you so much for a brilliant talk. You touched on so many important things and set an excellent stage for the coming talk. Sudesh Sivarasu is an associate professor of biomedical engineering from the Department of Human Biology, University of Cape Town. He also holds an adjunct appointment at the Northwestern University, Chicago, USA, as an international lecturer in global health and technology. He's a qualified electronics and instrumentation engineer with a master's and PhD in biomedical engineering from VIT University in India. He also conceptualized the multi-award-winning Frugal Biodesign, a unique medical device innovation methodology, and is a serial inventor and the recipient of the UCT DVC's Award for Achievement in Innovation, DST's Innovation Bridge Award, and then NSTF South 32 TW Kambule Award. Thank you so much, Prof Sudesh, for joining us.
Thank you so much, Professor Maswami, and thank you for having me in this forum. Can you please confirm if you're able to see my slide on presentation mode?
Yes,
okay.
We can.
Thank you. So it's been a pleasure to be on this particular forum, and just before the previous speaker, Dr. Justiaan, very well laid out the stage. So I want to talk about are we equipped to handle the trends? Are we always going to be following the trends, or can we set the trends? And how does the future of healthcare actually looks in Africa and in the developing countries? So it's a globally known fact. Lack of appropriate technologies affects delivery of healthcare. 2 out of 3 people lack access to essential health technologies. And I, as a medical device innovator and a biomedical engineer, feel that technology is a facilitator for delivery. And with technology, we can actually multiply, and we can actually multifold the amount of healthcare delivery that is happening. So imagine if 2 out of 3 people, 2/3 of the global population does not have access to appropriate health technologies, that's going to have a massive impact on how we are utilizing our clinical staff. And it's super important to understand the role that technology plays in healthcare delivery in the overall context. So just giving a little bit of background on the concept of frugal biodesign. It's a fundamental differentiation between how you innovate technologies to make the innovations fit in the context where they are supposed to be using. It's good to have the Rolls-Royce version of the technologies that we always aspire to have, but we also need to understand that the bicycle is the one that's going to work in our context. So, you know, we need to understand this contrast, and for which the fundamental of innovation, in my opinion, should be around where the problem is. And for medical technology, we need to focus the innovation on the clinicians and develop the whole holistic understanding of the life cycle of innovations, and then understand that and use that for healthcare delivery. So, who is the center of your innovation circle? This is a question that I ask my students when they come out to design new health technologies. Is it the patient or is it the doctor? And traditional knowledge always advises us to go with the patient. But I beg to differ with that. And I advise that the center of innovation relating to a healthcare or relating to medicine should be around the doctors. For simple reason that the doctors basically have the final say on what technology goes on to the patient. So we need to understand this, and we always get distracted with focusing too much on patients, but without understanding the fundamental differentiator in the whole value chain, who's going to make the final decision on what technology gets onto the patient. So I'm just sharing a few examples before going into the learnings. You know, FlexiGen, mobile handheld hysteroscopic device that we have designed. This was created with the unmet clinical need of actually women in rural Africa not having access to complex hysteroscopic procedures. And the technology innovation primarily lies in usage of this handheld hysteroscopic system to ensure that the procedure is done on a clinic, not necessarily in an operation theater. This kind of breaks the barrier of requiring specialist centers to do a procedure. This technology was actually created in collaboration with the clinician, late Dr. Carol Thomas, and we are in the process of commercializing this particular technology through a company called VastMedTech. Easy squeezy, simple, affordable, but a very fun, medical device that is used for actuating asthma inhalers was designed on the fundamental need that children below age of 12 find it extremely difficult to pump or actuate a regular asthma pump. And we needed to come out with an alternate solution. And we thought, let's make it fun for them. So we introduced cartoon characters. But the bunny ears basically give them the mechanical advantage of reducing the force that is required from 40 odd newtons to less than 12 newtons. So which makes it extremely easy for even children with less than 5 years, around 5 years, can actually handle this particular device. So our team was also part of the design team that designed and tested the National Ventilator Project ventilators, the CSIR Life Ventilator, and as we are speaking, the CPAP device that CSIR designed, which was tested in UCT, there is a plan to expand about 18,000 ventilators, of which 10,000 ventilators are already in clinical use and have been used across the COVID waves 1, 2, and 3. This is a simple innovation that using a mechanical mixer, which doesn't require sophisticated facilities, but more on what could work on the field hospitals, that has been implemented across South Africa. And we found a niche, or we identified a need for coming out with usability protocols. And the UCT Medical Devices Lab came out with the ventilator testing protocols. And currently around 5 different solutions, ventilation solutions that has adopted this usability protocol and have been approved or in the process of getting approved by SABRA. And some familiar faces on the slide here. A very simple innovation, the UCT visor that we used while when the COVID pandemic struck, and we have been successful in rolling out about 44,000 of these visors across South Africa. And this is a very simple technology that basically in interaction with clinicians like Prof Maswime and others, we were able to get this to understand the primary need of what would work in the clinic and what wouldn't. And then it helped in the easier rollout of technologies like these. Ubuntu booths again have been implemented in number of locations, and it's used for testing COVID patients. Food pools, And again, these are sequence of innovations which are very simple, but actually makes a world of difference in the place where they're being used. And in the process of this, the UCT is leading a consortium of for skills innovation called the Mediventors. And
more than ever, South Africa needs medical technologies to be homegrown. For this, we need optimally trained med tech engineers. Merseda, UCT, and 3 other universities and 1 industry partner have taken up the challenge. Students are trained through an integrated skills development program. Holistic learning means linking medtech projects to real-life market needs and creating industry links through the Mediventor Lion's Den student competition. 3 courses have been created as an extension of the current study material. MedTech Essentials prepares for regulatory and legal challenges. Systems Engineering and PLM teaches about product lifecycle stages. The Tooling course prepares students for high-volume production. Asynchronous e-learning means digital self-learning with assistance. The Virovent program drives sustainability, scalability, and localization. Mediventors, skills for medtech prosperity.
So, in spite of talking all about innovation and the value chain around innovation, I want to ask, my understanding on this particular space is that innovation in health always doesn't have to be technology based. There are more to innovation than just being a device or a technology. There is more of process innovation that is needed to get our implementation better. There is more for business model innovation that is required to make our solutions accessible. Always, it's not the cost of the technology that is making it reduce the access. It's the business model behind these technologies that's actually preventing the technology from being accessed across. And what is more critical is designing appropriate technologies than making it affordable. There's no point in creating a bicycle which cannot ride in a bumpy road. That we need to understand what could ride in the bumpy road of Africa. So it's super critical to understand and design medical technologies that are appropriate to the context where we are going to be using. And we always need to understand that technology innovation need to be cost effective, not necessarily cheap. So we need to factor in the full life cycle of a medical technology, and we also need to factor in the cost of ownership. It's we could very well have a 100 Rand solution, but what if it takes 1,000 Rands to maintain it? So that's one of the reasons why we have Africa has become a dump yard of donations of medical technologies. We don't factor these cost of ownership, whether you take it as a donation or whether you innovate these solutions. We need to understand that essence. But more importantly, I think the grounds are going to break between what industrialized nations and non-industrialized nations have through the fourth industrial revolution and even the fifth industrial revolution that we're talking about. So we need to factor in, are we ready for that? And is our healthcare basically ready to equip, or do we have what it takes to be championing or steering the way in the fourth and fifth industrial revolution? I think South Africa being having the massive youth population, we are best positioned to do this. And unlike the previous industrial revolutions, we don't need the physical infrastructure that is required that was only available in industrialized nations. Now we have a common ground that we can actually kick in and get going. So with that,
Thank you so much again for such an excellent talk, and I love the end of it, showing how the joy that the innovation and some of this brought to people. I'm going to move immediately to Katusha, and then at the end I'll ask a few more questions and comments. Katusha de Villiers, Katusha de Villiers leads the Bertha Centre's health-focused work while supporting project work within education, youth development, systems innovation, and innovative finance areas at the center. She teaches master classes on health systems innovation at the UCT Graduate School of Business, MBA and MPhil, as well as the University of Bergen and University of Oslo. She has spearheaded the center's developing understanding of health systems integration and the role of social innovators in health. Katusha has a master's in health systems administration from Xavier University, as well as a law degree from the University of Kentucky Law School and additional qualifications in project management. Thank you, Katusha. Handing over to you.
Yes, thank you so much. And actually, I'm grateful that I went after Sudesh because he brought up an extremely important point, which is that innovation is not just about technology. I think oftentimes that's a trap that folks fall into, that if you don't come up with a product, you're not being an innovator. And I think innovation should really be demystified. And I think if you've come up with a creative solution to a problem, go ahead, feel free, call yourself an innovator. Thank you very much for bringing up the slides, Denzel. We can go ahead and skip forward. I recently read the Lancet Commission on Global Surgery, and I was shocked to find out that over 5 billion people lack access to basic surgical care. And this is clearly a health equity issue, and it resonates with the work that we do at the Bertha Centre, because we believe that social innovation in health is a mechanism through which health systems can move closer to achieving health equity. Denzel, you can go to the next slide, please. When 9 out of 10 people cannot access basic surgical care, these are the folks that are the most marginalized. They're living in the most rural areas, and they have the lowest income, and they're disproportionately part of low to middle income countries. Denzel, you can go to the next slide. Access to health, I believe, you can sort of view it along these 3 dimensions, which is physical accessibility, financial affordability, and acceptability. And innovation in health falls sort of along these 3 dimensions. And I think you can really, when you look at these dimensions, you can appreciate that this is not just a medical issue, right? This is a geographic issue. This is an infrastructural issue. This is a cultural, financial, political issue. And you can't fall into the trap of thinking that healthcare is just medical. Healthcare is really a social issue, and that's why we really focus the work, our time and attention within the Bertha Centre on social innovation in health. And while our portfolio focuses on a range of social innovations and interventions, for example, we're working on health financing with the South African Medical Research Council at the moment, developing a social impact bond that is focused on reproductive and sexual health for adolescent and young women. Or we started the Innovation Hub at Groote Schuur Hospital, which you might have seen next to the canteen in the E-corridor. And we've also worked with the World Health Organization on developing community engagement packages. What I'm particularly focused on, and which I feel very strongly about, is frontline and community health work. And this for me has particularly been brought home during this COVID-19 epidemic, where I don't think any of us have been as focused on what it means to be healthy, I think, ever in our entire lives, and what it means for our community to be healthy. And Denzel, if you go to the next slide, you can see on the, and you can go to the next slide. Thank you. Yeah, if you can go to the next one after this, please. If you look at the surgical system, you can really see that the community is the building block of the surgical system. It ensures that nice referral pathway for folks who live out in rural and remote areas and who don't have access to the kind of critical health services that we maybe take for granted in more urban communities. And the next slide and the slide after that will give you a couple of examples of what I'm referring to when we talk about community health or when we talk about health innovation. The next slide shows an organization that I think many of you might be familiar with. It's called the Aravind Eye Hospital. It's in India. It's extremely famous. It's a Harvard business case study. So it obviously is, we can all learn a lot from it. It's an example of process innovation. You can see how they've set up their cataract surgeries in this sort of like assembly line format, which means that they are saving time. They don't have to do room turnarounds, things like that. But it's also an example of a business model innovation, the way that they subsidize care for poor patients. But it's also a social innovation in that it doesn't just look at eye care, but it also looks at what it can do for the community. So over 1,000 young women in rural and village high schools across India are recruited by Aravind every year and trained to perform nursing and other tasks. Actually, 80% of their workforce is made up of women. And these are young people that would never have had access to the labor market if it weren't for Aravind, for example. So Aravind is a great example of an organization that sees itself as part of the community. BRAC is another one, and that's on the next slide. BRAC is based in Bangladesh. It's an NGO. They are really doing an amazing job with mobile healthcare that they provide to maternal and neonatal and child health, where they're using that technology to connect community health workers and traditional birth attendants to the health system. So they are going door to door within their neighborhoods. They're identifying complicated deliveries and coordinating transport to local hospitals. This is very similar to organizations like Living Goods in Uganda. It's also similar to Last Mile Health in Liberia. So making sure that these folks in rural, peri-urban or remote areas have that connection into the health system, and they have a connection into the surgical system as well. But what if you live super far away? How are you going to combat geographical challenges? For example, if you live in a village in the Andean mountains or in the Amazon jungle, what are you going to do? How are you going to access surgical care? On the next slide, there's an example of an organization that does just that. It's the Centrandes Foundation in Ecuador. They've outfitted a 7-meter Isuzu truck. It is with an operating room. It has a swing room for pre-op and recovery. And it goes to local villages in very remote areas and liaises with the medical teams on the ground there to look after patients. You can see an example of them performing, I think that's a laparoscopy procedure on a patient. And they care for the patients after that locally, but then all of the post-op control is done via telemedicine. So folks who wouldn't have the opportunity to see a doctor and have that surgery that they need, this truck is able to do that for them. And I think there are examples here in South Africa. There's the Pelebox health train that is operated by Transnet and Roche, and they also provide, I think, basic surgical care or for smaller procedures as well. And then appropriate equipment is often really hard to come by in low to middle income countries. I mean, there are issues with electricity, repairs, availability. Liberia, for example, apart from a small portion of Monrovia that's on the electrical grid, they operate completely using generators. So how can you be sure that your necessary equipment is going to be functioning? And you often have to look for solutions that maybe the global north would sort of turn their nose up at. You know, if you don't have a functioning autoclave, pressure cooker can be used. And that might be horrifying to people, but it's a low cost innovation being used in a low resource setting, as it's reusing single use items. Gradient has created a universal anesthesia machine, and that's on the next slide. It's low cost. It's generates its own medical oxygen and functions without electricity. And the company is a non-profit and focuses exclusively on low resource hospitals. And I think they're operating in about 25 countries across the global south. So it's an example of medical equipment that takes into account the realities of what it's like to operate in low to middle income countries. And then Africa has always had historically low blood donation rates. There are ways to combat that, including Zipline, which many of you might have heard of. They deliver blood in Rwanda via drones. And then I found out on the next slide about this organization in Nigeria called J Blood Match, which uses artificial intelligence to connect blood donors directly to recipients via blood type. And then the donors sign up via Telegram or Facebook and receive text messages. I hope you can see an example of this text message saying, we really need you to donate. We need you to donate to this specific person because they're having this specific problem. And it's really been quite effective in a country where there isn't a sort of a culture of blood donation. It's not sort of culturally au fait. There might be religious reasons why they don't want to donate, but this is a way in which you can sort of demystify it. You're actually donating to a person. You can understand why it's needed. It's also a woman founder, which I really like. The next slide shows a local South African example of innovation. This is Pelebox. The founder is called Neo Huteri. He had TB and he had to queue for hours to get his medications. He developed this locker system. It's very similar to Amazon delivery lockers. You get a single-use PIN. You can go to the nearest location. They're all over Gauteng, and you can pick up your chronic meds, which of course means if you're compliant, you're less likely to access the surgical system. And it reduces the average wait time from 3 hours to less than 2 minutes. I really love this example of innovation, not only because it's local, but Neo was also one of our Bertha scholars. So we're very proud of him. And then finally, to address the issue of human resources shortages within global surgery, the next slide is about another South African organization. It's called the Umtonbu Youth Development Foundation. They are located in KZN and the Eastern Cape, and they really address the need for physicians and specialists in rural and remote settings. It's very isolating to practice in areas like that. So they specifically go out and recruit young people. They identify, train, support them via mentoring and financial support so that after their training, not only in medicine, but in other aspects of allied health, to go back into their home communities where they can provide medical services. And then my final slide is just some takeaways, which both Professor Swanevelder, Dr. Swanevelder and Sudesh have been talking about, which is that it's so important for us to think about, especially looking ahead, to think about the work that is being done as part of a collective impact. Medventor is such a great example of that, of all of these different organizations, these different universities coming together and working on this key issue. And through this collective impact, you're going to have a much greater result on the system. I think it's quite old school now to think about funding, for example, in development, to just be funding for improvement of one specific health outcome. It's much more that the pendulum has swung to funding collective impact. So if you're thinking about a BRAC or a Living Goods or an NGO that does work like they do, it's not only are you looking at community health work and how that improves the health system, but you're also looking at opportunities to create work for women, or for people who wouldn't necessarily have those chances to for employment. So it's an exciting time, but it also just reminds me particularly of how far we still have to go because of how complex this issue is. But I love these kinds of opportunities because it forces me to go and do my homework, and then I can see, oh my goodness, there's so many amazing innovators out there, so many bright minds who are coming up with absolutely mind-blowing work, and that's incredibly motivating. So I hope you find it as interesting as I do.
Thank you so much also for the brilliant talk. And yeah, I'm going to ask just some questions, or rather one question, and then we'll move on to the Q&A. But you know, as you're all talking, especially when Prof Swanevelder started, I remembered my own journey where I was, you know, medical officer or community service officer in one hospital, and I thought that the problem is in one facility. You know, that's all I could see, and I thought, okay, let me specialize so that, you know, I'm able to manage pregnant women. And after specializing, I moved into community obstetrics, thinking, let's try and solve the problems in Johannesburg. That's where I was working at the time. And then I realized the problem is across in, you know, the 15 hospitals that I was working in. And then I started getting involved in international work and realized we've got a whole continent and LMICs, it's everywhere, it's across the world. Even when I lived in a high-income country, I still saw some, you know, real problems that were there. And I think for the clinician, it's always, you think that the problems I see are just in front of me. That's why people don't think about solutions and think, if I walk away, if I go somewhere else, you know, I'll find a functional system. But when it's systemic issues, it's not, everyone is going through the same problem, they just don't know it. So I think this talk has really sparked a lot of thinking around seeing innovation as solutions, and much of it has been highlighted. The question I have for all of you is what opportunities are there for clinicians, especially who want to become innovators, you know, so career pathways, academic, for people who want to volunteer, who want to do more, what solutions, what pathways are there for them to get involved? Because so many of us think I need to finish my degree, specialize, and that's it. But not everyone is wired like that. You know, I've met a lot of amazing innovators who just don't fit into a box. And what solutions, what pathways would you suggest for them? I'll start with you, Prof Swanevelder.
Thank you, Prof Salome. I would say opportunities are unlimited. I would say if you work in a government setup, in a hospital like ours, or a hospital like anywhere in our country, then you must just look next to you And that's an opportunity for innovation and making a plan. I've had people, you know, you hear of strange ways how people change their immediate environment. If you can just give me, can I take 2 minutes and just show you 1 or 2 slides which I had, which I wanted to, just I didn't have time for. If you just bear with me, because it's about education. I've gone on to my slideshow. Is that a slideshow? I take it. So you are integral to Project Team Care. My good colleague and friend, Rowan Dace, Project Team Care. Where are they working? Most of the time in our hospital. They're training medical students, paramedics, nurses, allied health, all of us. And they train them in the most basic needs, something like resuscitation, something like intubation, stuff that may come normally for, you know, be quite normal for anaesthetists. But even now during the COVID time, if I think of how valuable it is just to look after a critically ill patient, we don't have enough people. If this is not your day job, then it's a very difficult thing. I think of my colleague, Professor Ross Hofmeyer, with his Storts Fellowship and the whole concept of innovating. It's across service, education, research. It all comes together, and it's teaching people who are medical students, who are interns, ComServe, and they are going out to other hospitals too. So it's about the multiplication of skills. We really need to invest in our human resources. His open access website is phenomenal and can be seen. It's for free to everyone. I'm thinking of our program, which has come and gone, and it's not always available, but specifically to the Surgical Society, we want to offer point of care clinical ultrasound training for medical students. We've done it over the years. It's just not formally incorporated into the curriculum. Where we use simulation nowadays in the simulation lab, it's all available to teach people and train people. So should we not be looking at super medical officers for our country rather than super specialists? You need super specialists to train super doctors. But I want every medical student who leaves our department and our country to be the best doctor they can be and be a super doctor. I mean, this should be achieved through distant learning and distant supervision, but also with intermittent focused training sessions. What other than a global crisis, like for instance COVID, can motivate global surgical innovation? Think how much has changed over the past 2 years just with COVID. Most of these innovations come out of need, and the best part of COVID is that we have upgraded all of our skills. As we speak, all doctors know much more about everything, epidemiology, the critical management of critically ill patients. Should we as institutions prioritize innovation and creativity when we are training our doctors? I can tell you now, and I'm extrapolating from our own department, the most important thing is to not stand in the way of good young people with good ideas. Don't obstruct, don't control, just let them go. All of the medical students, if you're good enough to be a medical student in our institution or any other in South Africa, you are an innovator. And just don't obstruct those people. Give them what they need, the opportunities, but let them go. And I can tell you, so I'm not going to go into all our devices that we've been involved, but all of this is just from our department, target control infusion devices, the intubator and intubator. These are all of these came out of need, and they're done by very junior people, junior doctors in our department. Activated coagulation machine. It is the financially, economically a cheap version of what is actually a very expensive tool. Tracheal dilators, and in the future. All I can say is we've been through almost 2 years of I didn't see that one coming. I mean, many things has happened over the 2 years. How can we plan for a future? which is unknown. So we have to sort it out on a political and socio-economic level. I think one of the questions was about social justice. It is 100% social justice we need to do, but it starts with working in a government hospital. Then you are an innovator for social justice. You can use the resource most completely under our own control. It is ourselves. We can do it ourselves. And I'm going to stop there with this slide and stop sharing. It is not the filling of a pail, but the lighting of a fire. It's all about scholarship, education, and development of our human resources. Thank you.
Thank you so much. I mean, so many excellent points there. Prof Sivarasu, how would you answer the same question about opportunities?
I think, thank you, Sarame. That's an excellent question. So we need to look at it more from a systems point of view, not rather focusing on the problem points. So I would say, take a few steps back, look at your environment, like how Dr. Justiaan just mentioned. There's a whole lot of problems that we can solve. Even if we don't solve, we can be the one that actually is the vehicle to take, there are so many bright minds here who are solving the problem. We actually need vehicles to take these solved problems into the hands of people who need them. And that's a gap that, increasingly we are not finding the right appropriate people to do that, especially on the clinical side. We need clinicians who can champion new technologies. We need clinicians who can champion new process innovations, new business models coming up. On all those things, we are not finding clinicians who can actually champion it, or there is a gap for it. And I think, as a clinician or as a clinical practitioner, it is super important to understand the various domains that you can contribute to holistically understand where is, we always tend to focus on how to deliver healthcare, but there are various ways you can actually deliver healthcare. If that means changing the way in which you operate, COVID has actually forced us to change the way we have operated, and we can't deny that. So I would say, just in the lines of what Dr. Justiaan just mentioned, go a few steps back, observe the background, and also, more importantly, understand how you have been trained. It is super important for us to understand that we have been, or clinicians have been trained in a way that is very traditional, but the times are changing and we need to adapt to what's out there. So how do we involve, or how do we incorporate the fast changing world? That's why I posed a question in my presentation. Are we ready for the fourth industrial revolution when we are still sitting in the second industrial revolution when it comes to healthcare? Because it's a common ground there. If we jump on the boat now, it's a common ground. If we wait on this, it's going to be again a catch-up game. So what can we do to jump to the next generation of healthcare? What is the trend that we can set in? That's a key aspect, and education and incorporating innovation is super critical in getting that. There are a few other aspects to touch, but I will wait for Katusha to respond.
All right, thanks, Katusha. Over to you.
I echo that this is a great question. I would just add that I would also encourage physicians to use their patients as a resource as well when they're thinking about innovation. When I was at the Grooteskier Innovation Hub, one of my favorite projects was called the Kidney Cares Clinic, and it was started by a young doctor in the nephrology department, and she really had an issue with her patients who weren't, her adolescent patients who weren't compliant with their treatment. And she thought, how can we make them understand the gravity of their situation? But the way she did that was to realize that she actually has no idea what it's like to be a young person with a chronic kidney condition. So she convened these focus groups with the registrars, with the nurses, with the doctors, with the patients, with their caregivers, to figure out what would be helpful for these young people who come over from Red Cross Children's when they have 12 years plus 1 day, and they're all of a sudden in a clinic with 45-year-olds, and they're still going through, puberty and figuring out what it's like to date and doing all of these things, and you can't speak to your doctor about these issues because they have no idea what it's like to be invited to a braai, but you have to be on a no sodium diet, or you have a stent, or things like that. And what they learned is that these young people just wanted to be with each other. So she created the Kidney Cares Clinic, which is for 12 to 25-year-olds. It doesn't matter what kind of kidney condition you have, you all go to the clinic together. And before that, you have a session with a psychologist, and you have a session with a nutritionist, and you're able to just kind of hang out. And one of the most interesting, or I think most impactful parts about that was that they also trained up slightly older patients from that group to be patient mentors. So all the young children, the young patients, had a patient mentor that they could then turn to and ask these kinds of intimate questions. I went to the movies for a date. What do you think I should do? And how, that kind of thing. And it has been such a massive success. And it was very simple. You just get the patients, the caregivers, all of the people around them. You have a talk. What do you want? And then address that. So don't discount your patients as an enormous source of inspiration as well.
Thank you so much. And I think, some of the key things that have come up is how doctors can be innovators, how students can be innovators, how patients can be, and how the community itself can be. But also for some practical advice for students, it's you can do short courses, you can do MS, there's the MSc in Biomedical Engineering, there's MBAs, there's the MSc in Global Surgery and the PhD in Global Surgery, just advertising. But there's lots of opportunities to think, if you think that you're a medical innovator and you want to do something that will enable you in the future to do this. But I'm gonna hand over to Fumi for 10 minutes of questions, and then we'll start closing up. Thanks, Fumi.
Thank you so much for a great discussion. Our viewers have definitely resonated with all that has been shared today. And a lot of the questions that have been asked by our viewers have actually already been asked in our discussion earlier. But just to expand, I will be touching on a few of the general questions that have come up. So the first question that we got from our panel was, how do we ensure that social justice and community engagement are at the forefront of our thinking while we innovate in our health systems? Can we start with you first, Katusha?
Oh, sorry, I'm trying to unmute myself. Am I unmuted? No. Oh, great. I'm so gun shy after my experience. I think the social justice aspect of it is I've touched on it a little bit already, which is this idea that that healthcare isn't a medical issue, healthcare is a social issue, and you can't by only focusing on can the patient get to the hospital, can the patient get treated, is not good enough. You have to take into account, where does that patient live? What kind of burden was placed on them to get to the hospital? And what financial difficulties do they have to go through? So if you go back to my slide where I was talking about the 3 dimensions of healthcare, that is really of access to healthcare, that I think that is really at the core of what you're talking about when you talk about social justice in healthcare. Is it affordable, appropriately affordable to the patient? Is it accessible, reasonably accessible? I mean, just because a clinic exists, it doesn't really help you if it's not equipped appropriately, or you don't have the specialist on call that you need to for your condition. And then finally, is it acceptable? And I think that aspect is maybe the most important, which is that people deserve to be given help or have their healthcare explained to them in a way that they understand. So, you know, we have a number of different languages in this country, but the language of government and the language of medicine is English. And there are a lot of people who will not understand complicated medical directives and might have to rely on their child to be their interpreter, and that is not appropriate. So how do we make healthcare acceptable to the people who are seeking it? It's a little bit of a roundabout question, but I'm going to answer to that question, but I'll stop there.
Thank you so much for that, Katusha. I will now be asking the next question that was brought up by our viewers. So the next question was directed to Prof Sivarasu. What is the process of implementing innovations and disseminating them to places where they are needed, and what are the major challenges?
Fantastic question for me. I think we need to understand that first and foremost, for us to understand the problem that needs innovation is to figure out the volume or the impact that the solution could bring. That's the most essential thing, and also we need to, as I said earlier, we need to take a step back to understand the circumstances around, understand the various stakeholders who are involved in the possible innovation. For example, if it is the community, just understand the dynamics of the community. If it is the clinic, understand the various role players in the clinic. If it is a rural hospital, just understand the dynamics behind that. So it's super important to understand that before you start to innovate. Then you also need to understand whom are you innovating this for? Is this for the hospital? Is this for the patient? Is this for the doctor? Or is it for somebody else? Is it for a totally different person? Okay, so we need to understand whom this innovation is targeted to. Subsequently, we also need to answer a very, very important question. Who is going to pay for it? Is that the patient? Is that the doctor? Is that the hospital? Is that the insurance? Do we have answers for this? Then think about what's there, what's already out there, and how is your solution different? If there might be another solution somewhere in rural Argentina, have you thought about it? Are you copying from that? Have you gotten the appropriate permissions to use it? We need to be legally protected as well. Check about that. That's the intellectual property side. The next thing is think about regulatory compliance. Are you allowed to do this? That's many a times, clinicians, generally in the clinical practice, I've heard a lot of clinicians actually say, I've made this in my garage, it might work, so I'm going to try it. No, you can't try it. You need to be compliant. We need to understand that. It may be something that is going undercurrent in the clinical practice, but you can't do it. You got to be you're answerable. You need to be compliant. So if you want to be compliant to SAPRA requirements, what is the process involved in that? You need to understand that. These are the things which actually brings out challenges, which actually inhibits innovations. But the more we talk about it, we can actually solve it. If we think about how just do a quick count on how many innovations have actually stopped at SAPRA level or at compliance stage level, then probably our interventions could be to ensure that we actually have ensured that we have systems in place to support innovations to cross the SAPRA barrier. If it is at the payer barrier, then how do we ensure that we get the ICD codes so that the insurance can actually pay for it? It's not only important to innovate, it's also important to innovate in the context of how your payer is going to consider, how your compliance agency is going to consider, how your clinicians are going to consider, and more importantly, how your patient is going to consider. And these are the challenges that if you as an innovator, you would want to solve this problem, you need to have answers to all of these questions. Because if you don't have answers to all of these questions, your solution, believe me, it's not going to hit the patient. It's going to be stopped by somebody or the other. But if you have answers, you don't need to make the answers. That's the super critical aspect of this innovation, is to collaborate. you don't need to do it all by yourself. Make sure that you have the expertise who can actually help you pass that bridge. Make sure that you have the compliance person who can take you through the separate requirements. Make sure that you have somebody who can design the business model so that you can focus on your core business, which is innovating, which is solving the unmet clinical need. And again, many times I see that clinicians say we don't have access or we don't have this technology to solve this particular problem in this particular clinic. Is that a universal problem? You want to put your, it's as you understood that there is a whole lot of things to solve here. Think about a problem that actually would have a maximum impact or would change lives of multiple, volume of people. So think about that. And are there challenges? There are definitely going to be lots of challenges. It's all about making sure that you have appropriate systems in place to mitigate these challenges, and for which, going back to my previous comment, educating on what are the various aspects that are needed to ensure that those challenges are met, to ensure that we are aware of the systems that requires, or to be aware of the system, the stakeholders is again very important. So it's again a roundabout answer, but I think it's definitely something that we need to. It's not to say that it's difficult. It's to say that we need help. And we need to collaborate. That's the crux.
Thank you so much, Prof Sivarasu, for highlighting the importance of contextual innovation and the need for collaboration. I now hand over to Yejin, the Vice President of Surgical Society.
Hi everyone, my name is Yejin Zhang, and as Fumi said, I'm the Vice President Internal of UCT Surgical Society. Firstly, I'd like to thank all of the speakers who have presented today. The global surgery webinars have been extremely successful, and it's all thanks to our amazing speakers. Innovation is an important aspect of our future, and this talk has been such a great way to expose our undergraduate members, but to also provide healthcare professionals with an insight into the future of our field. You guys can hear me, right? Okay, sorry. All of the speakers have echoed that innovation in health does not always need to be technology-based. I really liked Prof Swanevelder's opening that it is all about people. I think we can often get lost in the word innovation and relate it to new objects, technology, and tangible things. But at the end of the day, it is all about the people we serve. Thank you for reminding us about why we do the things we do and for inspiring us to tackle the problems in our backyard. Dr. Sivarasu, thank you so much for your insight on the application of technology as a means to deliver healthcare. It is so inspiring to see that all of this innovation is happening at our fingertips. I couldn't stop smiling throughout the talk. What I found to be very important is that we should look at the problem and provide tailored solutions through technology that is applicable and acceptable in our context. Katusha, thank you for your insight and emphasis that the community is an important pillar of innovation. Thank you for showing us that innovation does not only occur in the urban high-tech setting, but as importantly in the rural peri-urban settings. Just some things that stood out for me is that innovation does not have to be complex. It can be simple but useful, and to utilize innovation as social justice. The text message on Katusha's slide from the blood donation organization read, "Are you available to be a hero?" And this talk has inspired me so much that I feel like I need to go and do something right now. Thank you again to all the speakers for igniting this fire in us today. Last but not least, thank you to Prof Maswime and to Fumi for your vision and execution of this webinar and the Global Surgery branch of SurgSoc. Thank you to our audience for joining us today. You can find our webinar series on the UCT Surgical Society YouTube channel and look out for our Innovation Month in September. Thank you.
Thank you, and thank you to you as well, and for making this possible. I'll just close off with a very few words. I mean, now you all want to go and innovate, and to just say pause, don't rush. It's not as simple as that. And I think a very important message from this was that we need to create an enabling environment for innovation in the Faculty of Health Sciences, and that's important. But there's also principles of innovation. and not every innovation. Some innovations are damaging, as it was put forward. So we need to follow the principles of innovation. Get a mentor, get a collaborator, get involved with innovators. Don't just run into it, because you might find yourself doing things that might be unethical. But in closing, I would like to say the future of healthcare is very bright, and we can all play a part in solving global challenges locally. Thank you very much. Have a great night.